All right, thank you for coming this afternoon. And I wanted to start off by just echoing thank you to Jill Corbin and the Schubert Center, thank you to Betsy Tracy and the Mandel School for supporting this event. We are very excited to present the results of our study. And I want to say that this study really came about because of Julia and Susan. So they came to me 2 years ago saying, there's an RFP for a grant. We want you to be the mentor for this project. Would you be willing to write it with us? And so I looked at the call, and what it was focusing on was promoting child well-being for children who have been maltreated, but then also focusing on establishing and training the next generation of our leaders in the child maltreatment field. And so we were thrilled to receive the grant from the Children's Bureau, and it is going to be a treat for you because you are going to be listening to the leaders of the next generation. So we have 3 studies that we've done as part of this grant. The academic competence study, which was done by Adam and myself, the internalizing symptoms study, which was done by Susan, and then the early substance use study done by Julie. So our agenda for today is I'm going to lay the foundation for our 3 studies. I'll talk about the background. We'll move into the 3 different studies presented by each of us, and then I'll conclude the session with some overarching themes of our results as well as the implications. So those core take-home messages from our grant. And then we'll have time at the end for questions. All right, let's get started. So in 2014, which is our most recent prevalence data, we had 3.5 million children reported to Child Protective Services in the United States. And what resulted from that was over 700,000 kids being victims of maltreatment. And now when you look at the types of maltreatment, the majority is neglect. So that's 75%. 17% physical abuse, 8% is sexual abuse. And then we have this other forms category, and this is because each state defines child maltreatment differently. And so some states would include emotional abuse, other states would include exposure to domestic violence, some states would include parental substance use, and so those are all lumped into that 7%. Now when we're thinking about specifically about Ohio, we actually fall right in line with the numbers. So we're 25,000 victims, just about 25,000. And what this breaks down to is 9.4 children out of every 1,000 child is a victim of maltreatment. So when we're thinking about these numbers, this is 1 year, and this is the rate for 1 year. But there's been research that has been done that has looked at how many kids experience maltreatment over their lifetime, and that number increases drastically. So what happens is that turns into 1 out of 8 kids every. That's not the overflow. Here, let me just move this up here. Sorry, we have an overflow room, and we need this mic over here a little bit. Okay. So 1 out of 8 kids is a victim of maltreatment from the point of birth to 18. That's a huge number. Maltreatment is a complex issue. And so when we're thinking about maltreatment, we're thinking about the type of maltreatment. We're thinking about the severity, the level of harm, whether it's chronic maltreatment happening over a longer period of time, co-occurring. So is it co-occurring with other forms of maltreatment? Is it co-occurring with other forms of violence, such as intimate partner violence or violence in the community? And then we're also thinking about timing. So the timing that the maltreatment is happening in relation to the child's development. So researchers have been trying to figure out, are these specific characteristics related to specific outcomes? And what we see in the literature is that there's no real patterns that are emerging yet. And this is relatively new. Most of the research that's been done dichotomizes maltreatment. So yes, the child was maltreated. No, the child was not maltreated. So in general, what we see is that kids who are maltreated have more behavioral problems. So that would be aggression, delinquency. They have more mental health problems. So this would be anxiety, depression, PTSD. They have more cognitive problems, so difficulty with memory, difficulty concentrating, and difficulty with academic success or academic competence. They have more physical health problems, and so they're more likely to have chronic health issues, and they're more likely to have developmental delays in terms of their brain development. There's social problems, so they have difficulty forming, they're more likely to have difficulty forming peer relationships, having pro-social behavior than non-maltreated children. And then finally, they're also more likely to use substances and to become substance dependent later in age. So when we're thinking about the risk of maltreatment, we also have to consider that there's other risk factors that are associated with maltreatment and with these outcomes. And so these would be things like poverty has been linked to both maltreatment and the poor outcomes. Caregiver substance use is another one. Caregiver mental health, so having more mental health problems they're more likely to have kids that have these problems. Placement instability is also a risk factor. So if you don't have a caregiver that is consistent, they're more likely to, that permanent caregiver, they're more likely to have these problems. And what I would say here is that this is complex because there's so many risk factors that could be associated with these problems. But what's even more challenging about this is that there's theory and some preliminary research that's showing that some of these initial problems could be linked to future problems, so some type of cross-domain relationship. So some theories suggest that kids who are maltreated experience mental health problems, and then down the road, they may experience substance use problems. So this issue gets more and more complex. All right, so that was the bad news. The good news is that the research also shows that there's variation in outcomes. So this means not all maltreated kids have these poor outcomes. In fact, when we look at the data cross-sectionally, we actually see that between 10 and 20% of kids who are maltreated show positive adaptive behavior. And this is what we think of resilience. So the capacity for successful adaptation in the face of adversity. So meaning, even though these kids were maltreated, they still have the potential to thrive. And this really gets to the core of our research. So we came to this question of, what makes kids who are maltreated, what makes them resilient? And so Susan and Julia and I, we combed the literature, and we started to identify those factors, so those protective factors that would contribute to better outcomes in maltreated children. And what we came upon were that they grouped into these three groups, which nicely aligns with Bronfenbrenner's ecological perspective. And so we have the individual level, we have the relationship level, and the community level. So these are the three levels of the social ecology. So I'm going to talk about each one of these levels and the protective factors that have been identified cross-sectionally in the literature. All right, so the individual level, what we see is that kids who go to preschool are more likely to have better academic outcomes than kids who do not go to preschool. So those are of a maltreated population. We also see that kids who've been maltreated who have positive social skills, so the ability to be cooperative, assertive, responsible, also tend to have better behavioral outcomes as well as academic outcomes. When we look at the relationship level, we see the caregiver is a prime factor in this. So the caregiver's well-being. So this would be absence of mental health or substance use problems. If a caregiver does not have those problems, their child is less likely to have those problems as well. Caregiver warmth and caregiver cognitive stimulation. So these are things that would be the parent is being responsive to the child, they're answering questions, they're correcting the child, giving them hugs. So these have been shown to be influential in a bunch of these different domains that I just talked about. And then finally, permanency. So if the child is remaining with the same caregiver, they're more likely to have less behavioral problems. And the final factor is community. And so what the research has shown that there's a couple different areas that community has played into children having better outcomes. One of the areas is neighborhood safety. So if children are living in a neighborhood that has lower levels of crime, lower levels of violence, they're more likely to have better outcomes. If they're living in the same house over time, they have stable housing, that's also a protective factor. And if they have neighbors that are supportive, so if you think about collective efficacy, we're all in it together, we're going to raise these kids as a group, this has been shown to promote those positive outcomes as well. Okay, so back to this picture. So we have the literature now. We've identified these potential factors that could contribute to all of these outcomes based on the cross-sectional literature. And going back to the theory, it's not that each one of these individual levels of the socioecology affects the child's outcome, but it's actually an interaction between these groups, these three levels. And when we're thinking about this, it's not a snapshot in time. So the child is continuously developing. And so we have to think about how these variables, these levels of the ecology, protective factors, could potentially influence the development of children. So our studies focused in on these areas, these core areas of development from birth until 14. And as you'll see, we decided to span our studies across all of it. And so some of our studies focused earlier, some focused later, but we wanted to really get an idea of where do these protective factors and risk factors influence the development of these outcomes. So we have three overarching questions that run across all three of our studies. So the first is this variation idea. So because research has shown that 10 to 20% of children are resilient, what would this look like in terms of longitudinal research? Does that hold? We wanted to look at risk factors. What are the specific risk factors for child welfare populations that would promote or be associated with those poorer outcomes? And then we also looked at protective factors. So what are the factors that promoted better outcomes? So all three of our studies used the National Survey of Child and Adolescent Well-Being, so NSCOP. This is a national representative study of children who have been reported to Child Protective Services. Some of these children have substantiated cases and some of them did not. Some received services, some did not. The total sample for the Child Protective Service data was 5,501 children. The age span at the first time point ranged from birth all the way up until 14 years. Data were collected from 1999 to 2007 at 5 different time points. And they collected data from the child, if they were 11 years or older, from the current caregiver, caseworker, and then in some instances, the teacher. All right, so I'm going to hand it over to Adam to talk about the academic competence study.
I feel too badly with this clicker. So thank you. First, I'm really humbled to present here with three tremendous social work scholars. My dad is a social worker who worked for about 3 decades in the juvenile justice system, so I can't think of anything I would rather be doing right now. So this study, what we did, so in the same model that Megan already presented, I'm just going to give a few other details. So what we're interested in are looking at whether there are diverse and distinctive patterns of academic growth or academic competence among the children in the sample. And then not just looking at the patterns themselves, but looking at what influences being in a particular pattern. So if you can imagine that, so children develop differently, and we would want to see what influences children developing on one path or another. What causes them to go down one pathway or another. And so that could be things like the timing or the type of maltreatment. It could be things like poverty or education level as risk factors. And then there are the set of protective factors that Megan already mentioned. So I think she mentioned caregiver warmth, stimulation, those sorts of variables. So for this subset of the study, we looked at just over closer to 1,800 children. They were from birth to 5 years at the first year, and they were residing with their biological caregiver. So that distinguishes them from the total sample. you can see, so they're a little bit closer to the younger side, between the age of 1 and 2, slightly more male, and it's a pretty diverse sample. So there's a lot of diversity in the group, lots of racial and ethnic minority children, and there's a range of education level, and most of the folks were living below federal poverty level for them. The measures that we used for academic competence actually span there are 3 core measures, and the reason for that is because when you have children 0 to 5 who you're following for 5 years, that they sort of age out of the first measure that you used in them. So the preschool language scale is this kind of flip chart. Some of you might know it, or it's like an easel, and there's a picture maybe telling a story about a teddy bear that fell on the floor, and so depending on the age of the child, the test is a little bit different, the domains are a little bit different, but you're sort of asking the child to say, okay, what happened here, and can they relate the story and the scale, and the mini battery of achievement is a little bit different than that, and it's more along the lines of it's a subset of this other Woodcock-Johnson test of achievement. It's a smaller, earlier version. It's for kids as they're slightly older. Now, in order to deal with this problem of developmental stage and measurement, what we did was we took the percentile rank of the children within the wave that they received the test, and we sorted them into deciles. So, or quantiles, but we chose deciles. So, were you in the top 10th, the bottom 10th, so at each of those ranks. And then what we do is we follow them over the course of the study to see, okay, do they hop from one decile to the other in order to estimate trajectories? And that'll be a little bit clearer when you see the plot of what it actually looks like. So the maltreatment variable was the parent-child conflicts tactic scale. This was caregiver reported, and it measured all the stuff Megan talked about: physical abuse, psychological abuse, physical neglect. We also look at the timing, so whether it happened, and timing here we define by developmental stage, infancy, preschool, or school-age children. And then poverty was measured, I think I already mentioned that. Caregiver education was a simple dichotomy of whether they had a high school. The protective factors were measured with a caregiver report of preschool attendance. There's a pro-social skills, the social skills rating system to measure social skills. These are things like cooperation, assertion, self-control. Caregiver warmth was measured with the Holmes scale, and this is measured by observation by a rater. So the rater observes whether there's good warm stuff going on, hugging and kissing, positive things that we view very positively as positive interactions. Cognitive stimulation. It's a subset of the same scale, but it's more interactive. So, are they responding when the child asks them a question, right? And then parental well-being was measured with a short form of the CD scale, and it's a symptom rating. And so it's a total number of symptoms, and we're operationalizing that as did the caregiver have any or not. Neighborhood safety was measured using this community environment scale, and it's the caregiver perception, so how they rated the safety of their neighborhood on the scale. So this slide is a little tough. As the methodologist on the project, I felt it was my duty to explain how we did all of this. So we used a cohort sequential latent growth mixture model, and that doesn't mean a lot. And to talk about kids, I thought the most appropriate thing to do would be to think about how I would explain this to my sort of preschool-age son who's 5. And I probably will fail at that, but I'm going to try anyway. So let's imagine that we have a pond, and from that pond, we grab a giant bowl full of many, many tadpoles, hundreds of tadpoles, right? And what we know all the days that the tadpoles were born, we kept track of that, but we have a constraint, right? The constraint is we're only allowed to go visit the tadpoles every 3 days, okay? We can't see them every day, right? And we're really interested in knowing how fast these tadpoles grow. They're all the same species. They're all green frog tadpoles. So we're really interested in knowing how fast they grow, especially because there was a bunch of toxic oil dumped into this bowl of tadpole. And we want to know which ones are the ones that continue to grow fast and right, even though this bowl was polluted, right? So but we encounter a problem, right? We can only visit the bowl once every 3 days. So what do we do for the points when we're not able to measure the tadpoles? And they are all different ages, right? So we keep coming back, we're like, well, was this one the one that was big on the first day, or was it like small on the first day? So we have this problem. So to do that, we come up with this table, like it looks a little bit like this. This is sort of a simplified version, and this is an ages timetable. And what it does is it allows us, I have to do this with my hand. So it allows us to take in the NSCOS study, the folks who were measured at 4 waves, right, and they were 5 ages, right? So they're all within 1 year, they're 5 ages, right? And so what we do is we take that group and we sort of spread them out like this, and we imagine as if we measured the folks who were, what would have happened if we had taken the 5-year-olds in wave 1 and talked to them 5 years ago, right, when they were still 0. And we do the same thing with the ones who are only going to be 5 at the end of the study, right? And so we estimate where they would be, even though we weren't there at the bowl looking at them on that day. If you didn't get it, it's okay, but that's, you know, I worked on this for a while. It's the best I can do for cohort. All right, so the results of that really fancy statistical model are presented here, and this result is just, the other thing is, so we can use that model once we discover that there are these hidden subgroups of children, some of whom have various trajectories of academic competence. Then we can relate other variables to those trajectories. But first, we just want to look at, well, what are they like? And so Megan mentioned, there's some evidence that shows, well, lots of kids are resilient, right? Is 10 to 20%. And we see that here. Actually, we see a little higher than that. So that about a fifth of the kids are in this, they sort of have a high, they're the 80th percent. So across ages on this sort of imagined developmental cycle that we create using statistics, we see that that group is persistently doing really great. And then there's another resilient group which is kind of interesting, which is this purple line, which are folks who at the intercept, so at their sort of first basic measure of academic competence, they weren't doing as well, right? They're sort of well below the 50th percentile. And you can see that there are 2 groups there, but something happens with one of them sort of takes off and does better, right? They sort of improve despite the circumstance of being a maltreated child. And then you have this red line of folks who are at the bottom and they're never improving, and that's about a fifth. And you have another group that started high, but was less resilient and didn't stay there, right? They dropped over the course of their development. And then there's this sort of, I would describe as a slightly more mysterious developmental group that also started high, plummeted, recovered, and then seems to, right around the age of 9 or 10, which I don't know that that's coincidental, right? That's a sort of important adolescent transition age for children. And so they seem to be falling off again at that last data point. But I think this is a really important advance in how we think about resilience among children. So, and the one way to illustrate that is to think about, so a lot of you are caseworkers or have been or know some. So if you are and you're seeing a child at one point in time, right? So what you have is like a snapshot of this figure. So what you have is like right here, right? And so you only see, and so these kids look the same at the time that you see them. But over the next 10 years, what happens to them is drastically different, but they look the same when you saw them. And the same thing can happen at other time points. So here, these 2 children look the same, but they're on sort of really opposite trajectories. One is improving and the one is worsening. So the next set of slides are designed to say, well, what are the things that we can look at that will help give us some cues as to which one of these child might be in. So to do this, it's tricky. So we're just going to compare 2 at a time. Right, we're 5 at a time comparisons are mind-melting. So we're going to stick to 2 at a time. So here we compare this top-level green trajectory with sort of the worst one at the bottom of academic competence development. And you can see, so we have the notes here at the bottom are more that physical abuse when you're preschool age is associated with a higher odds of being here in the red line than being in the green line, okay? And neglect during infancy is also associated with a higher odds of being in the low trajectory of academic competence rather than in the higher green trajectory. And so are being male, being a racial or ethnic minority, and having a caregiver who has less than high school level of education. They're all associated with being in the lower as the not resilient group. So those are the risks for being here as opposed to more resilient. This next slide looks at a comparison with the other trajectory that we're calling resilient, which is this more growth trajectory. The more interesting finding here is that sort of conversely to the previous, right? So males are likely to stay, being male makes you likely to stay in that top level of trajectory, but being female makes you likely to grow out of the lower percentile and be on this path of growth as opposed to the lower trajectory. So the message there is that really the effect of gender is very complex, right? It's not a sort of simple decision. So there can be benefits for both genders is the way I would describe it from the two slides. And similarly, having a caregiver with less than high school education is also bad for you when comparing these two paths. For the protective factors, we go back to the same, comparing the high, flat group that's resilient with the low, red group. And we see that children who have higher pro-social skills at the baseline interview have a higher odds of having this high, resilient level of academic competence. And caregivers with higher cognitive stimulation, if you have a caregiver like that, you're also more likely to be up there. And you're also more likely to be up there if you have a caregiver who demonstrates more warmth. In terms of the odds here, I don't make too much of the fact that that's a small number. This has a little bit to do with the variable skill and the one unit increase measure associated with a 0.44 increase on odds. So that's the measure from 10 units more substantive to be associated with bigger increase. Right. And you see the same effect bearing the low level of academic competence growth trajectory. We're also calling resilient is that caregiver have that resilient path. And if you're saying the same with pro-social skills, having high pro-social skills really sort of sets you up. And I'm going to hand it back. I'm going to give you the back of the process. As Jill mentioned, I am a social worker. I'm a sociologist.
Okay, so what do these results mean? So Adam actually described some of what I'm going to say right now. So we found these distinct patterns of academic achievement. So we found that some kids were in this resilient group and some kids were not as resilient group. What I want to say here and emphasize is the idea of a snapshot. So when you're doing an assessment, you are taking a snapshot of where these kids are. And if you look across, so for example, this purple line that Adam was talking about, this kid is in the 40 percentile up to the 50, and then back down to the 40 or 30. And so depending on when you do your assessment, the child may have very different outcomes to play. And so what we're suggesting here is that there should be some type of ongoing or multiple time points of assessment for these outcomes of maltreated children. The second point that I want to emphasize is that when we looked across neglect, physical abuse, and psychological abuse happening at the 3 different times of development, we actually only found it for this early group, so this early age group from 0 to 4. And so when you look at the graph of where it's highlighted, you actually see a lot of movement, which would suggest that this is that key time in development that sets the foundation for future years. So if we're going to focus our efforts on timing of when we intervene, we want to focus on those early years because we may have the potential to change those outcomes for kids. The next finding that I want to just emphasize is that pro-social skills was significantly related to better academic outcomes. And so there has been some research done looking at social skills improvement programs. If we were to use social skills improvement programs, those could potentially enhance these academic outcomes and promote resilience. I want to say that with the caveat of this next result, though, because I think this is the more interesting one and the one that we could really focus our efforts and our resources towards. So caregiver warmth and cognitive stimulation, that was significantly associated with those resilient outcomes. And so we want to try to have interventions that promote these sensitive type caregiving, these appropriate verbal and cognitive responses in order to promote those outcomes. And if we do this, our results suggest that we have the potential to change the outcome of those kids. That having those type of caregivers will change the trajectory, the long-term outcomes in terms of academic outcomes or academic content. Okay, so I'm going to pass it over to Susan.
So before I begin, I just want to say that I am very grateful for this opportunity to present my work, and I'm very excited to share my findings with you. So using a very similar technique and approach that Megan and Adam did for their study, I looked at risk and protective factors that are associated with developmental trajectories of internalizing symptoms among maltreated children. And I had three main goals. So the first one was to explore diverse and distinctive developmental trajectory patterns of internalizing symptoms. And my second goal was to examine how risk factors, including maltreatment characteristics, such as the type of maltreatment, level of harm from maltreatment, and the timing of maltreatment, may be associated with distinctive trajectory patterns of internalizing symptoms. And lastly, my third goal was to examine how and if protective factors at the individual and at the relationship level would be associated with more resilient outcomes. And my study sample included 541 children who were between ages 4 and 5 at baseline. And here's what my sample looked like. So approximately half of the children were 4 years old, and the other half were 5 years old at baseline. And approximately half were males, and a little less than 50% of the sample was white. And in terms of caregiver characteristics, approximately 77% of the caregivers were biological parents, and a little over half were employed and had either a full-time or a part-time job. So in terms of measure, to measure the outcome variable, which was internalizing symptoms, I used Child Behavior Checklist, CBCL. So this was a caregiver-reported measure, and the data were collected at 4 time points from time 1 through time 4. And for maltreatment characteristics, I assessed 3 different variables. So first one was maltreatment type. So I used caregiver-reported parent-child conflict tactic scales and also CPS records to examine these 4 different types of maltreatment. So physical abuse, sexual abuse, emotional abuse, and neglect. In terms of the level of harm, CPS workers were asked to indicate the level of harm to the child caused by maltreatment. And the responses were coded either as more severe level of harm to the child versus less severe harm. And maltreatment timing, this represents the age of onset of maltreatment. So this was measured using the CPS records, so prior history of CPS reports. And kids who first experienced maltreatment at age 3 or younger were coded as an earlier onset group, and kids who first experienced maltreatment at age 4 or later were coded as later onset. And in terms of individual level protective factor, child prosocial skills were measured using the social skills rating system. So this measured caregivers' perception of their children's prosocial skills, including cooperation, responsibility, self-control, and assertion. And at the relationship level, caregiver well-being was measured using the 3 scales from the Composite International Diagnostic Interview, which measured caregivers' depression, alcohol use, and drug use. The caregivers' responses on these 3 scales were summed to create a composite well-being scale with higher scores indicating better well-being. So here's the results. So this study found or identified 3 very distinctive and different trajectory patterns of internalizing symptoms among maltreated children. So first, approximately 75% of the children were in this blue group, which represents the consistently low internalizing symptoms group. So children in this group exhibited consistently low level of internalizing symptoms over time, so throughout the study. And approximately 16% of the children were in the red group, which represents the increasing stable group. So children in this group started in the normal range of internalizing symptoms, but their internalizing symptoms grew over time. So they exhibited gradually increasing internalizing symptoms until they entered school. And their internalizing symptoms stayed pretty stable and even slightly decreased during the school age period. And the remaining 9% of the children were in the green group, which represents the decreasing internalizing. So children in this group exhibited clinical levels of internalizing symptoms during early childhood, and followed by a gradual decrease over time. And it should be noted that although this group represents decreasing patterns, children in this group exhibited significantly higher levels of internalizing symptoms throughout the study compared to children in this resilient, consistently low internalizing symptoms group. So what risk factors predict membership in those 2 more problematic internalizing trajectories? So compared to this group, this blue group, which is the resilient group, and which is the consistently low internalizing symptoms group, children who were emotionally abused and children who were indicated as experiencing more severe level of harm from maltreatment had a higher probability of being in this decreasing group, which means that emotional abuse and more severe harm from maltreatment, more severe level of harm from maltreatment are associated with clinical levels of internalizing symptoms during early childhood. And again, compared to this consistently low internalizing symptoms group, which is the blue group, children who were sexually abused and children who were neglected were more likely to be in this red group, in the increasing stable group. So this means that sexual abuse and neglect are associated with increasing internalizing symptoms over time. More hopeful and positive news or finding is that child prosocial skills and caregiver well-being were found to be significant protective factors. So children who had higher prosocial skills and children who had caregivers with better well-being were more likely to be in this resilient group, this consistently low internalizing symptoms group, compared to these 2 other groups. So based on these findings, the following implications are suggested. Because my study found very diverse and distinctive trajectory patterns of internalizing symptoms, and because different maltreatment characteristics were associated with specific and distinctive trajectory patterns, clinicians should be providing a thorough assessment of children's maltreatment experiences to understand their unique and different maltreatment experiences, and should provide individually tailored interventions to children. And also, it is suggested that ongoing monitoring of behavior development is provided, because some of the children in my study, they did not exhibit internalizing symptoms until they reached later developmental stages. So if clinicians only focus on internalizing symptoms at the time of maltreatment investigation, they would fail to spot these serious internalizing symptoms that develop at later developmental periods. So maybe providing brief follow-up would be useful or helpful in identifying serious later internalizing symptoms. Also, this study found that emotional abuse, sexual abuse, neglect, and more severe level of harm from maltreatment are associated with poorer outcomes and more internalizing symptoms. So more targeted and intensive interventions should be delivered toward this high-risk population with these risk factors. Again, child-proof social skills were found to be a significant protective factor that is associated with more resilient and positive positive behavioral outcomes. Therefore, providing social skills enhancement programs, such as group-based social skills training programs, may be helpful in preventing negative developmental pathways of internalizing symptoms. And lastly, intervention strategies should not only focus on children, but also on caregivers, because this study clearly suggests that caregiver well-being matters, and caregiver well-being is a significant protective factor. So intervention emphasis needs to be placed on accurately identifying caregivers' substance dependence and depression treatment needs, and effectively addressing those needs through evidence-based intervention. This is my study.
Hi, everybody. It's an honor to be here today. I'd also like to add that part of my doctoral training was actually at the Schubert Center. I worked as a policy research associate there, so it makes it a special honor to be here today. So my study focuses on early substance use, and I don't mean happy hour. I'm actually talking about early onset substance use, which is occurring at a younger period in adolescence. And the reason I was interested in focusing my study on this is because evidence shows that early substance use is a risk factor for the development of actual substance use disorder. So a lot of adolescent substance use is normative and temporary, but when it starts earlier, is a higher risk for substance use disorder. So my study had two parts. First, I was examining the prevalence of early substance use. And so I wanted to examine whether how substance use rates in the child welfare population compared to the general population. And I also looked within two major child welfare subgroups, children in in-home care and children who are placed into out-of-home care. In the second part of my study, I'm looking at what predicts substance use. So I'm looking at maltreatment severity, specifically physical and sexual maltreatment severity as risk factors for early substance use. And I'm using a mediation analysis to examine internalizing pathways to this substance use. So this is often thought of as self-medicating behaviors. So if a child has problems such as depression and anxiety, he or she may use or use substances, to alleviate these behaviors. So I'm testing this theory as it pertains to a young adolescent population. This also, by the way, extends my colleague Susan's research. If we're thinking about her research is showing how maltreatment leads to higher internalizing behaviors. So here we can think about this particular developmental stage of 11 to 14-year-olds who may begin to be susceptible to early substance use due to internalizing behaviors. So for my first study, I have a sample of 896 eighth graders from the NSCA. And once again, I'm looking at an in-home care group and an out-of-home care group. And then for my general population comparison, I used the Monitoring the Future study. This is an annual study of students that's done to assess the national prevalence of substance use annually. And so this is actually a population of 69,000, so a much larger study. And the NSCA has, the Monitoring the Future study has very nice, detailed, disaggregated tables that I was able to use to build a data set for comparison. So here are my findings. These are sample demographics. So the sample was pretty evenly split, male and female. Within my NSCA sample, less than 10% were placed in out-of-home care. And by the way, these are unweighted counts and weighted frequencies, so they are representative of the overall child welfare population. As we would expect, there were racial and ethnic differences between the two samples. So it's well established that racial and ethnic minority groups are overrepresented in the child welfare system. And this was also reflected by significant differences in race ethnicity between the NSCA study and the Monitoring the Future study. So higher percentages of Black non-Hispanics and Hispanics in the child welfare group. My measures were substance use, and I looked at lifetime prevalence of substance use as well as current substance use. And I focused on 3 substances which seem to be particularly pertinent to early onset use, or kind of the initial substance use behaviors, and these were alcohol, marijuana, and inhalant use. Inhalant use includes things like nail polish, gasoline, many different types of often commonly available household substances that can be abused. And then I looked at placement types. In general, I was expecting children in out-of-home care tend to have higher levels of traumatization, higher levels of other mental health problems, and so I was expecting to find higher risk in that out-of-home care group. And here are my results. I was a little surprised in my results. I hypothesized that I was going to find higher prevalence of early onset substance use in the child welfare population. But as is shown here in this slide, for the most part, I found no differences, no significant differences between the two populations. So on the slide, the dots are the estimates, and then the little whiskers that come out of the dots are 95% confidence intervals. If the 95% confidence intervals are overlapping, that means there's no significant difference. If they don't overlap, that means that there's a significant difference. So in this case, all of my confidence intervals are overlapping for 30-day marijuana use, lifetime marijuana use, and also 30-day alcohol use. And this is true for the overall NSCA sample as well as the subgroups. Here is an even more surprising finding. Here I found lower prevalence of lifetime inhalant and alcohol use in the NSCA study. So you can see 6.7% use inhalants in their lifetime for NSCA overall versus 16.6% in Monitoring the Future. And for alcohol, there was a somewhat smaller difference, but still significant. Important caveat to this, when I broke it out by placement group, this pattern was only maintained for children in in-home care. So children in in-home care had lower prevalence of these substances than the NSCA than the Monitoring the Future general population. But there are no differences between children in out-of-home care and the general population. Here we find a somewhat different and concerning pattern. So this is looking at current levels of inhalant use. And here I'm actually finding no differences between the general population, the overall child welfare population, and children in in-home care. However, I am finding higher incidence of current inhalant use among children in out-of-home care than the general population. So this is concerning because here we're talking about current levels of use. So this is use that's likely occurring while they're in an out-of-home placement. And what this may mean is that it's difficult for out-of-home caregivers to protect these children from using substances that are commonly available household goods. So we'll talk a little bit more about the implications for this in a moment. So in general, my study found that, contrary to what one might expect, for the most part, there are comparable or even lower rates of early substance use in the child welfare population versus the general population. However, an important exception to this were children's early substance use among the out-of-home care group. So for that group, there were higher rates than the general population. And what I really think that this shows is that there's a need for caregiver education on this, as well as a need to educate youth on the risks associated with inhalant use. Because we know that inhalant use can be associated with very severe neurological effects, as well as even sometimes death. And so we need to make sure that youth are aware of these often overlooked substances. Okay. So the next part of my study examined a past model predicting early onset substance use. And so here I'm focusing on 11 to 13-year-olds. I have a sample of 796 youth. Here are the demographics for that group. About a quarter were in out-of-home placement. More than half were female. A third had active caregiver substance use. This is another risk factor for early substance use and potential confound in the relationships that I was studying. So I did examine this as a control variable. In terms of, I examined physical abuse severity and sexual abuse severity. About a quarter had any physical abuse, and almost 20% had any sexual abuse. And about fewer than 20% had any early substance use. Now keep in mind, I'm looking at 11 to 13-year-olds here. So this is a low incidence behavior due to the young age of the group. Here are the measures. For early substance use, I focused on any use of alcohol, marijuana, hard drugs, inhalants, and prescription drugs. Once again, I examined physical abuse severity and sexual abuse severity. So for physical abuse, I used the parent-child conflict tactic scale as what I did was I actually developed a severity scale based on this. So looking again at the importance of maltreatment characteristics, this ranged from 0, no physical abuse, to 5 being the most severe form of physical abuse, which was being threatened by a gun or knife. I used caseworker report for a sexual abuse severity scale. This ranged from 0 being no exposure to sexual abuse, and then all the way up based on the degree of invasiveness of the sexual abuse, to 5, which was intercourse. For problems of internal well-being, I looked at post-traumatic stress as well as internalizing behavior problems. Here's my past model that I assessed. First I examined the relationships between sexual abuse severity and the problems of internal well-being. So internalizing behavior problems and post-traumatic stress, I expected to find positive relationships between those. So higher sexual abuse severity being related to higher levels of internalizing behaviors and post-traumatic stress. In turn, I expected to find the internalizing problems to be related to higher levels of early substance use. And then I expected the same pattern of relationship for physical abuse severity. So here are my findings. So first, let's look at physical abuse severity. As hypothesized, I found positive relationships between physical abuse severity and internalizing behavior problems, as well as post-traumatic stress. In addition, there was a significant direct effect of physical abuse severity on early substance use. This supported my research hypotheses. I also found a significant indirect effect. And what this is doing, this is providing some evidence of self-medicating behaviors. So physical abuse severity was related to higher levels of internalizing behavior problems, which in turn were related to higher levels of early onset substance use. For sexual abuse severity, my hypotheses for the most part were not supported. So I found a significant relationship between sexual abuse severity and post-traumatic stress, as I would expect, but none of the other paths were significant, and I didn't find any mediated effects evidencing self-medicating behavior stemming from sexual abuse severity. The R-score for my model was 0.11, so this explained about 11% of the variance in early substance use, and what that means is that substance use is really complicated, and a lot of different things, trauma and other things contribute to it. All right, so getting on to implications. A key finding was a significant indirect effect from physical abuse severity to internalizing behavior problems to early substance use. And this shows the salience of internalizing paths to early substance use in child welfare samples. It shows the importance of integrating mental health and substance use services, because these are two related things. And so also from we're in a school of social work, we need to think about training social workers who are skilled in both areas as well. It also, as the past studies have been presented, shows the importance of comprehensive assessment for maltreatment history. So my measures aren't looking at yes, no, was I maltreated, but they're actually examining the severity of maltreatment. So it would be important to have that level of detail in clinical assessment as well. All right.
Okay, so we presented a ton of results. I'm going to try to wrap them up very quickly so that we have time for question and answer. 3 areas we focused on. I'm not going to go over those again. So what did we find in terms of variation? We found that there are diverse and distinct outcomes for kids, and this is good news because this means that there are kids that are resilient, and we saw this across all 3 studies. And so some of these maltreated children are resilient. These are the findings for our risk factors across the 3 studies, and interestingly, there's different characteristics of maltreatment that was related to these different outcomes. So this is supporting that notion that different characteristics, level of severity, as Julia just mentioned, may be specifically related to certain types of outcomes. More research needs to be done in this area. For protective factors, across both academic confidence and internalizing symptoms, we found that prosocial skills was important. And as I mentioned earlier, what we may want to invest our resources in is this second level, this relationship level. But what's interesting is that across the 2 studies, we actually found different results. So for academic competence, the responsive, stimulating caregiving promoted that resilient behavior for academic achievement. For internalizing symptom studies, caregiver well-being promoted better internalizing, so less depression, less anxiety. So that makes sense, right? If we're cognitively stimulating our children, they're going to have better outcomes. If we are not depressed ourselves, if we're not anxious ourselves, our children are likely to have less of those outcomes. But what's important here is that these contributed to those resilient groups. And so those would be the type of interventions that we would want to focus on. All right, so I've said this, Susan said this, Julia said this, ongoing assessment. So if we're thinking of these snapshots in the children's development, that we do at least a brief follow-up in order to see if there is a change in that child. And if there is a change, those would be the children that we wanted to continue to assess to make sure that they're on the resilient path and not on those declining paths. We want to focus our services, of course, high quality, individually tailored, and we want to focus them on the caregivers, because I do believe that if we focus them on the caregivers, this social skills improvement area, that will naturally promote the child's better outcomes. All right,
So thank you for joining us. What we're going to do is we're going to quickly move up here, and Jill's going to help facilitate some of the questions. So let's